Good morning, everybody. First of all, of course, I would like to thank DBMed and IQ Medical for inviting me to give this lecture on this symposium. So I would like to present something about the history and the development, and then about the ideas we have on what are the main, I would say, advantages from the clinical point of view of visualizing tubes together with the uterus and the ovary, which is the whole tract you need for a normal ovum pickup. And that's why we adopt a little bit more and talk a little bit more about virtual laparoscopy, because this is the only non-invasive way to see the whole tract of the female genital organs which you need for a normal ovum pickup. So that's why we say, well, virtual laparoscopy perhaps is a better name than ExEm Foam or HyFoSy. Let me see. Well, I do have a conflict of interest because what has been said already, I'm one of the co-inventors of this technology, which started with gel. I will come to that in a minute. And I do get royalties, and I have shares of the company of IQ Medical. And what many of you probably don't know, that I'm also the inventor of hysteroscopic morcellation. So I invented MyoSure and TrueClear as well. That means that if I'm talking about intrauterine surgery and mention hysteroscopic morcellation, don't trust me. In 2007 we introduced a gel, ExEm gel, as a contrast medium for sonohysterography. It offers a much more stable filling with the uterine cavity than the common use of saline infusion sonography. And we say it's not infusion, it's installation. The image is very stable, it's very clear, and especially if you do 3D imaging and with surface rendering, you get these beautiful pictures. And we were very proud to be on the cover of Fertility Scan quite soon after we did our first publication on the use of gel instead of saline. The gel gives more details, as you can see here, and it looks very much like as if you're doing hysteroscopy, like in this retained products of conception, which we see more and more now that we do less DNCs for abortions and miscarriages, but we do more medical treatment, so we see more and more retained products of conception, which you can treat very well with hysteroscopic morcellation, so don't trust what I'm just said, but anyway. You can see secretory endometrium like this very, very nicely as well. It's very common, they look very similar, and it even becomes nicer if you do surface rendering, 3D surface rendering, and you get images like this. This is virtual hysteroscopy. So this is as if you're doing hysteroscopy with a rear view mirror. We are looking from the fundus all the way down, and you can actually see the stalk of this polyp in the more isthmic area. And this is a typical imaging of a blood clot. You know, you can see the fibrine vessels almost. So it's not only us, but it was acknowledged, and it was also seen in the Leuven group of Dirk Timmermans, and they confirmed actually what we found as well, that the gel installation compared to saline infusion is feasible, it's an alternative, and it has less technical failures. But then the question arose from many gynecologists in Europe, especially from some areas where we got a lot of questions on, can you see tubal patency with the gel? And then we said, no, we cannot. You know, because the gel is too viscous. It should stay in the cavity. That's exactly what it's designed for, that it gives this beautiful imaging and this distension of the cavity. So it's too viscous. And if you want to have it in the tubes, you have to dilute it. But if you dilute a gel, you will get air bubbles. And air bubbles with ultrasound are a disaster. You know, they create horrible artifacts, and you think that there's something in the cavity, the white dot, but it's just an air bubble. But while we were working on this dilution, how can we dilute the gel without creating air bubbles, we well, I personally got rather frustrated and said, well, it's not going to work, and I mixed it all up, and then suddenly I realized that, but if we create not only a few air bubbles, but if we create many air bubbles, we might have something else. And at that time, it was the only contrast that was available in 2011 were the last years of Ecovist. It was already told by the shearing company that they will get the product off the market. And saline and air, the HyFoSy alternative was horrible. We couldn't see the tubes, so I think it was not a very nice technique, a very difficult technique as well. So we had the feeling that this might be the solution. And actually, if you do this, you create microbubbles that form a foam which is stable for several minutes. And this dilution is very simple. It's 1 by 1. So half of it is sterile water and half of it is the gel. And that's what you get in your package as well. You see, it's 5 and 5. And then the viscosity is 90% reduced, so it goes very easily without any pressure into the tubes, because there is no need to pressurize contrast media to fill the tubes. And then, well, this is the pictures you're probably very familiar with. We advise always to start in a longitudinal plane and then move to the transversal plane, go for the corneal areas and try to find the intramural part where the tube is leaving the uterus, and then follow the tube. And in this case, this is not an easy case, because there's a lot of peristalsis from the bowel, as you can see. And here with the left tube, you can see that it is quite adhered to the posterior side of the uterus, as you can see here. Well, I think many more beautiful videos will follow today. I'm quite convinced about it. But if you see an image like this, where you can see actually the black, small black pieces, which are not, this is not the air is white. The black things, the black bubbles, no, not bubbles, but the black drops are the original gel, surrounded by air bubbles. So if you see the black drops going in a thin tube, you know that it's patent. There cannot be anything else than that it's patent. So we wrote down our first, well, description of the technique in the white journal, and followed quite soon after that with our first experience, and we were quite happy to well, to mention that this probably might be something which could be followed by others as well, which actually was the case. So up to date there are 38 PubMed publications already about this technique, and we're quite proud that, well, all of them are positive about this technique. What is it now exactly? Well, it is glycerol and hydroxyethyl cellulose. It has no additives, so it's quite pure. It's patented, CE marked, and FDA approved. So more than 1 million tubes have been tested now in over 60 countries in different areas in the world. There's no proven allergic reactions, and there are no infections either. And also the first one to confirm our results and state that HyFoSy is feasible, accurate in the diagnosis of tubal patency was the same group from Louvain, from the Timmermans. So they acknowledged quite soon already, immediately after the introduction of the technique, that it was something which could be confirmed by others. And then a lot of other publications came, almost all about the clinical use of it, and compared with classical hysterosalpingo-Graphy, and especially as a first-line method to do this procedure initially as one of the first pillars, I would say, of the subfertility workup. And some attention also on what you see on the Slovenian study that was about using the foam as a confirmation of a well-performed sterilization, in this case with Assure, which was very popular in Spain as far as I know, and I've tried it as well, so it's still very sad that the product has left the clinical, well, you'll probably agree, in Spain we were very happy with the product. But you could use it very well, as you can see here, as a confirmation of your blocking of the tube, although we feel that there is no tests which definitely demonstrate that the tube is blocked. There are only tests which demonstrate that tubes are open. Tubes can always have a spasm and it looks as if they are blocked. But anyway, after an Assure procedure, it was well recognized that you can use it as a confirmation of an effective sterilization. Anyway, and then, of course, many well-written studies came from Spain as well, and I will not go into details because I think many of the authors you will meet here and they will present about their own results, and here is another one of people you know very well, and we are very happy that Spain is so active in adopting this technology for tubal patency testing. Some other centers look more about the typical visualization, and many of you will probably know the name of Caterina Exacustos. She's very well known of HyFoSy and now HyFoSy as well, and she makes beautiful images like this still, which shows very nicely the three-dimensional with surface rendering of the foam. And especially this one is very interesting because it's of course computerized with the people of General Electric, and they were very helpful. But what you can see here is that the cavity is not expanded at all. It stays very flat. So it proves that it really is a very low pressure system, and you don't need a balloon catheter to fill the cavity, right? Because now what did the computer was told, we only want to see the gel, we don't want to see anything else, and then you get images like this. And here you see how flat the distension is. There is almost no distension, and the foam is going into the tubes by itself almost. Then the issue of pain. One of the first studies about the comparison of pain with classical hysterosalpingography was from Amsterdam, and it was a very simple randomized controlled trial, simply, with a primary outcome of pain experienced during the procedure measured by visual analog scales. And it's very important, which is the last sentence, that the infusion of the contrast was done automatically by an installation pump. So you could not influence the rate of infusion, which could influence pain as well. And what they found is that the pain scores were significantly less with the use of foam instead of classical hysterosalpingography. And this is a Turkish study which showing the relation between anxiety and pain. And there is, of course, and that's all what you could think of, if there is a higher level of anxiety, probably patients will experience more pain, and pain experience is subjective. So we were very happy with this Spanish study, which will be demonstrated today as well, which shows that HyFoSy is lowering anxiety and pain, both if you compare it to hysterosalpingography. This is, as you can see, of the number of authors, one of the largest study which is performed in the Netherlands about the use of foam. It's a randomized trial comparing the use of foam and classical hysterosalpingography. It's compared as a first choice tubal patency test, and we were very proud that this publication, this study, actually won the Congress Prize paper at the ASRM in Philadelphia in 2019, which was just a few months before the technology was FDA approved in the United States. And this was actually at the end of the trial, so the publication became 2 years later. What the study exactly did, we were not involved, so it was an independent study, and the only thing the IQ Medical company did was they provided the ExEm Foam for free. But it was an independent Dutch organization who funded the study, and this is Dutch tax money, so it's quite independent. And then you see that a lot of hospitals participated, 26, and well, perhaps for Spain that's not a high number, but in the Netherlands 26 is 1/3 of all hospitals in the Netherlands. We have 75 hospitals in the Netherlands, so 26 is quite a lot. And the primary outcome was the ongoing pregnancy leading to live birth within 12 months after the randomization. And what was found, that if you look at the management based on Histerosalpingo-Foam or on HyFoSy, the end result was exactly the same, as you can see here. This is the image from this year's publication in Human Reproduction. So it seems that it's equally effective if you want to see what your next action will be in your clinical management. It equally fast leads to a pregnancy. And there was confirmed also in this study that the pain was significantly less with HyFoSy compared to classical Histerosalpingo-Foam. So their end conclusion was management based on the results of HyFoSy or Histerosalpingo-Foam leads to similar pregnancy outcomes, and it's significantly less painful. And no conclusions on the therapeutic effect couldn't be drawn because the study was not powered for that. Then a very beautiful study came at the beginning of this year from a center which is presented by our next speaker, Inès. She will come to the stage in just a minute, I think. And they have a wonderful training site, and they introduce a very nice and simple classification, which we definitely like to adopt, because it's simple, and simpleness quite often is a beauty. So you describe the uterine cavity, segment 1, which is the intramural part, segment 2 within the tube, and segment 3, which is the overflow, which is the foam around the ovaries. And then quite recently in the United States, the American College of Radiologists acknowledged also that HyFoSy is there. It's something new in the United States, but they state already from reading all these publications that HyFoSy has an improved accuracy and a better concordance with laparoscopy if you compare in 2 and 3D, if you compare it with air and saline, the only available HyFoSy for many years in the United States, which has changed with the introduction of the foam now. And this is important as well, there are no more surprises. We had a discussion with the Americans about what to do if we found a hydro with the foam. And we realized, well, you don't find a hydro with the foam because you see it already with your plain scan. So it's never a surprise. If you see an image like that, you will not start to use the foam, of course. While with classical Histerosalpingo-Foam, you don't see anything. So you can be surprised by a hydro. Anyway, I think this is one. We had already, so the take to work, I never say take home message. I think you shouldn't take your work too much home, so I always talk about take to work message. It's less painful and time consuming than Histerosalpingo-Foam. It's accurate and safe, single operator. You can do it in an outpatient setting. There is no need for X-ray. It is less patient unfriendly. Please don't use the word patient friendliness in our profession. I think nothing we do is patient friendly. Everything's patient unfriendly. So all we can do is make it less patient unfriendly. And it has similar outcomes for infertility. The ovum pickup, virtual laparoscopy, well, you're all aware of what we mean with the ovum pickup. It's the movement of the cilia and contractions of the smooth muscle in the fallopian tubes which propel the embryo, the fertilized ovum, towards the uterus. And if you see the foam visible from the utero-tubal junction, from the intramural part, all the way down to the ovaries, then you see the whole tract you want to see, the whole anatomical needs you want to see. This is a beautiful image, if you ask me. That you see that the ovary is floating, as you could say, in the foam. There's foam around the follicle, as you can see here, foam on the dominant follicle. So it shows very nicely the anatomical needs for a normal ovum pickup. What we just said, and this is the only non-invasive technique which is capable of imaging this. So you could call it virtual laparoscopy. And then last but not least, this is a remark of the European Radiological Protection Competent Authorities, which tells us that people should not get X-ray when it's not necessary, and they have the right to obtain a diagnosis for a right examination, and they can start a treatment without delay, and doctors should avoid any unjustified exposure to ionizing radiation. So this is what we learn to our patients, what we should learn to our patients, that if they are advised to have an X-ray, the patient is allowed and should ask the doctor, is it really necessary to use X-ray? Because I heard or learned that there are alternatives as well without using ionizing radiation. This is European policy. Great, so this is not my work, as you mentioned. This is a whole team behind it. As you can see, a lot of people. And I would like to thank you very much for your attention. And I give the word to the next speaker, which is Inès, with a very difficult family name, I can tell you.
So good morning, everybody. Thank you, Professor Emanuel, and I would like to thank the organization for inviting me. So my name is Inès Abdennebi. I'm a French. It's difficult to say, but you can get used to it. You will have forgotten it in 1 hour. And I'm a French gynecologist. I work in a French hospital in Créteil, which is just near Paris. And I would like to introduce to you the concept of Fertility Scan. That is a concept that we have developed in with my team, which is a concept that allows a whole examination for fertility in one time. So I'm really sorry for my French accent. I will try my best. So what is the Fertility Scan? So the Fertility Scan, it's an all-in-one ultrasound for infertility evaluation. It's in one time a combination of different exams. First, a classic pelvic ultrasound, and we are really looking for using 3D ultrasound. We can use also hysterosonography if it's needed. It's not always performed during this fertility scan. And then the HyFoSy, and all this examination takes around 25-30 minutes in just one time to make a whole examination, an anatomical exploration, but also a functional exploration. I will show you that just after. And so for us, it's the first line exam in infertility evaluation for our patients, because I work in a fertility center. So for us, it's a way to do all the exams in our center at the same time. So first we do an ovarian exploration. We can do at the same time an anatomical and functional exploration, and also we will assess the ovarian reserve. So first with the antral follicle count using SonoAVC antral mode or SonoAVC follicle mode. Like you can see on the little video, it's precise, and today I think it's used by so many people to do a very precise follicle count. We will also check if there is an ovarian mass. We will also assess if the ovaries are accessible, if they are mobile, and this will be important for the treatment, because those patients will maybe have IVF, and for the oocyte retrieval it will be important to precise on your report if the ovaries are accessible, if you can take them down to do the retrieval. And also we will assess the ovarian function by assessing the follicular maturation compared to the date of the cycle. So if you are at the 10th day of the cycle and there is a pre-ovular, a very big follicle, it's important to know, and if there is no maturation at all, it will also be informative for the cycle of the patient. We will also assess the endometrial maturation, because looking for the endometer, it will be a reflection of hormonal impregnation. So it's also a reflect of the cycle. If you have a very big follicle, but the endometer is very thin and not impregnated with estrogens, it's also informative for us. Just after that, we do tubal and peritoneal exploration. So like Professor Emanuel did just say, we look for hydrosalpinx, we look for endometriosis, we look for contraindications to the exams that come just next. And we do also a uterine cavity assessment using the 3D, so to check the uterus dimensions. And we also use the coronal slice to look for anomalies of the cavity of the uterus, like polyps, like myomas, for example. So the 3D is very important to see if the sonography has to be done, and for the rest of the treatments. If you have a doubt about an anomaly of the cavity, you can do a sonography. So sonography, it's the instillation of a little bit of saline solution in the uterus. For example, on this uterus, you can see you have a doubt of a polyp, and with the saline solution in the cavity, you highlight these anomalies, and the sonography is very easy to do. It's very fast. It's around 3-5 minutes. Or gel also, yes. When we have a doubt, we can do both, but with the gel we can also see these anomalies. So we like to pair the two exams, because you can do a sonography and just after do the HyFoSy. You just have to re-aspire the saline solution. And to finish the fertility scan, we do a functional evaluation of the fallopian tubes. So we check the patency with the HyFoSy. And like Professor Emanuel did just say, our team has published a classification to standardize the description of the patency of the tubes by describing the different portions of the tube, and to speak about the same thing when we do a report, because HyFoSy is a dynamic examination, so you have to believe your report if you didn't do the ultrasound. So like this, we can all talk about the same thing on our report and understand where it's blocked or not. Fertility scan is also important for the treatment, because it's an assessment of anatomical reproductive organs, but it will also be useful for the treatments after, because for HyFoSy or for sonography we use a catheter that will be the same catheter that we use for intrauterine insemination or for embryo transfer. So it's also a test if the catheterism is difficult. If you have difficulties to pass, you can write it on the report, and you can explain how to do, or which catheter you had to use if it doesn't work with a simple one. And for the fertility scan, it doesn't take much material, because compared to the HyFoSy alone, it's just you have just to add a syringe of 20-50 milliliters and saline solution, and for the rest it's only like for the HyFoSy. I think we will discuss it just after. So when do we have to perform the fertility scan? Usually we are used to perform ultrasound at the 3rd day of the cycle, but we recommend to do it better after menstruation. First, because when the patient is bleeding, she has pain, she is ashamed, she don't want to have an ultrasound, it's not the best time to do it. So we prefer to do it ideally between the 5th day and the 12th day for the woman's comfort, and also for the examination, because at the 10th day, for example, you can assess if there is a follicular maturation, if there is an endometrial maturation, but when the patient is bleeding, you cannot do that. And it will also ease the examination for the HyFoSy. When the patient is bleeding, she can have tubal spasm due to the bleeding. And for the sonography, you can also have fake images. So after the period, it's better to do this test. So to conclude, it's a single examination that will do all your evaluation, and it will be important for the patient, because when they consult in fertility clinics, they will have a lot of appointments, they will have a lot of exams, often painful, with a lot of anxiety. And here, with just one time, you can you can assess everything. It's time saving for us, for the patients. It's economical and it's very well tolerated. Oftenly, the patients who has a fertility scan, they tell you, I almost felt nothing, or it was not painful, or I have read on Google a lot of things and I was really afraid, and finally it went very well. So this is my team, the persons with whom I work, so Professor Nathalie Massin and Dr. Jean-Marc Levaillant, and we have published a publication about the fertility scan which explains more in detail what I just explained you, so if you want to read it. And we are very involved in France in the training of French doctors. So we have created the École E3F. E3F means ecography, formation, femme, and fertilité. So ultrasound, formation, women, and fertility. And the ultrasound school, we make formations for French doctors. They can be gynecologists, they can be radiologists, they can be midwives, because in France midwives can do this type of examination. And they come during one day to have lessons, but also to assist to real ultrasounds. What it's called? Okay. Okay, so you see how it happens. So each day, it's once a month. Sorry, around 50 doctors come to attend to the formation. They have lessons that with theoretical lessons, with images, with pictures that are commented, explained to them. And after, they have what we call live patients, with real patients that come to have their ultrasound. There are around 4 or 5 a day. They will have the ultrasound, and the doctors go 2 by 2 to assist to attend to the examination, to see how it works, how we do the HyFoSy technically. And the ultrasound is retransmitted on a screen on the other room, and other people can watch the ultrasound, and it's commented by the echographist. They can ask questions, and we make days about fertility scan. We also make days special for endometriosis, and these days are really successful. We have the next dates are already complete, and people really like this kind of formation. And with our center, we also created a university degree, which we have called Ultrasound Exploration of Infertility. We have around 50 students each year. And during a year, they will have courses, and they will have lessons to get used to pelvic ultrasound, and will have also practice with us, because they have to come to attend to our ultrasounds during a certain number of days. They really enjoy it also. This is the third promotion of the university degree, and they will have soon their exams. Thank you for your attention.
Sometimes I think it's very interesting, the fertility scan, but sometimes in the first days of the cycle, if you can estimate the reserve, the ovarian reserve in the first days, but sometimes it's difficult to assess correctly the 3D image of the render of the uterus, no? Despite malformations, because if the endometrium is very, very thin, it's difficult. Do you repeat in case of that? So, but in a secretary later in the cycle?
For malformations with 3D, we don't find it difficult, because we do it like around the 8th, 9th, 10th day of the cycle. So we have already a very large endometrium. So we can see very well the shape of the uterus, and we can see like polyps that we cannot very well see at the very beginning of the cycle. When we do the fertility scan, it's a little bit later, so it's more easy to see it. If needed, yes, we can repeat the examination and sometimes we do the fertility scan and we see that we are already too late for the HyFoSy. So for example, we say to the patient, you come next month, but a little bit earlier in the cycle.
Okay. But if you combine it with the foam is very well capable of recognition of shape of the uterine cavity. You will miss small polyps, so we advise always to start with if there is suspicion of anything in the cavity, to start with saline or gel. But if your endometrium is too thin to observe the shape, because that's, I think that's what you mentioned. Then with the foam you will perfectly see the shape of the uterine cavity.
When you finish the HyFoSy, you after do a 3D. It's in it.
Yes, you can, of course.
After.
Yeah.
If
you're
before and after.
If there's any doubt about the shape.
When you are waiting to the product to go in the tubes, you can do an acquisition of 3D acquisition of the uterus and do a reconstruction, and you will see very well the limits and the form of the uterus. We try to aspirate all the saline that we can. If it's not enough, you can take off everything. You tell to the patient to get up. it will jump, and with 5 minutes, all the saline is gone, and you can do a HyFoSy very well. And if you can manage to take off everything first, you don't have to change the catheter. You just take off the syringe, and you take the other syringe, and you follow the examination without too many manipulation.
You agree sometimes the presence of saline may interfere with the diffusion of the gel.
Yeah,
yes.
And you dilute the foam as well.
Exactly.
Yes.
But you can check after aspiration or removing the syringe with the saline or the gel. You can check how the cavity is before you introduce the foam.
Yes, and we don't prepare the product before be sure that we can do the examination. So for example, I personally don't open the kit before being sure that the catheter goes well, because after you have to throw it, for example. So I put the catheter. If I'm sure, I say to the patient to hold it, and I will prepare the product. And for the sonography, it's the same. You do the sonography. If you see that you can take off all the saline solution, you say to the patient, okay, we won't do this today, we will do another appointment, but most of the time you can do it all in the same time during the same day, and it goes well.
Okay.
So this classification, we have described 3 portions of the tube. There is the interstitial portion, which is in the muscular part. Oh, okay. So you remember the picture. There is the peritoneal portion, which is all the length of the tube, and here you can describe it goes until the 2 centimeters, 3 centimeters on this portion, and the third portion is the ampulla. How do you say?
Yeah, ampulla.
Ampulla.
Yeah, ampulla.
And the ovarian.
Fimbrial part.
Yes, fimbrial part.
Fimbrial part.
So you can say, and we distinguish left or right. So for us in French, it's droite or gauche, so D or G, and we say D1 to 1, L1, L2, L3. So you can say the patient is L3, G3, L3, right. You understand? D3, G3 in French. It means that
it's how to make something very simple complicated,
yes.
isn't it? Yeah.
I have to translate everything.
And the spasm is the first picture.
Yes, the spasm, and you can also describe how much part of the tubal, the spasm, if it's all the interstitial portion that is not patent, so it's a spasm, and you can see, you can say, I think there is a spasm because it's D1, G1, and a lot of time it's a spasm.
It's straightforward, simple, no discussion. I think it's brilliant.
I think
like the foam.
I like it very much. Yes. Nice.